Morning. It's indeed an honor and a pleasure for me to welcome you all to the very first session of the Healthcare and Life Sciences track at TC18. It's such a pleasure to see the healthcare audience grow by 25 to 30% every year since we commenced the track in 2015. I'm Andy Day. I'm the Senior Director for Healthcare and Life Sciences at Tableau, responsible for the industry strategy and marketing globally for providers, payers, pharma, and med devices. I'm one of the co-founders of the healthcare vertical. And it is indeed an honor to introduce our speakers for our very first presentation to kick off the Healthcare and Life Sciences track, driving efficiency and improving bottom line in using compelling visual analytics at Stamford Health. This is an amazing story about a mid-sized healthcare system really deploying Tableau strategically across the enterprise, thanks to the leadership of our speakers here, Dr. Divya Malhotra, who's the Executive Director for Analytics and Innovation at Stamford Health. I have 3 master's degrees across 3 countries in business and engineering, but I'm just overwhelmed and honored to introduce her because she's a medical doctor, she has a master's in public health, and she's an MBA. And it is a visionary leadership that has really led to the success that you're about to witness. She's also a certified Six Sigma Black Belt. Luis Rodriguez is part of our team and is a senior project manager in the Department of Analytics and Innovation. Widespread experience across asset management, financial management, and analytics. He has an MBA from Tulane and also holds a certified financial analyst and a new one, chartered alternative investment analyst, which is an exotic designation and has contributed to this phenomenal work. So with that brief introduction, Dr. Divya Malhotra and Luis Rodriguez from Stamford Health. Please greet them with a big applause.
Can you hear us? Okay, great. Thank you, Andy, for that introduction. Now I really feel like I need to live up to this after that, but thank you so much for joining us on this beautiful Tuesday morning. We're excited to present our journey and our lessons from our analytics deployment and some of the use cases that we will be presenting to you. So I guess this is not working. I'm going to try to, can you see that? Okay. All right, so just a quick overview of what we'll be doing today. I'll spend a little bit of time, not too much, on talking about our analytics journey at Stamford Health, a little bit about ourselves and what the lessons learned and some key takeaways from our journey. Then we'll deep dive into the actual use cases. We have a lot of use cases, so we want to spend the chunk of most of our time on that section in the middle, talk through some of the finance, revenue cycle, operational, clinical quality, and population health use cases. And then just a quick snapshot on the next steps and future direction. It's not. If you can. All right, so a little bit about Stamford Health, just quickly. We are a single hospital system, so we have 1 hospital, 305 beds, but we do have our own employed medical group, and you'll be seeing a lot of use cases that are developed for our medical group. So we have about 120-ish physicians, both primary care and specialists, in our system, and some stats for 2017. We have about 15,000 inpatient discharges, 18,000 surgical procedures, 400,000 outpatient visits. So that's kind of the information on our, okay. Thank you, that helps. As we dive into analytics, it's important to understand our competitive landscape. So we are in Stamford, Connecticut, which is very close to New York City. So we're in a very intensely competitive market, as you can see through this map. A lot of hospitals up and down the I-95 corridor. So there's a hospital every 2 exits. So it's very intensely competitive. So that is a huge impetus for us to keep our decision making and our business decisions and our clinical decisions data driven. Okay, so now about our journey. I purposely started this presentation using this slide because this is a snapshot of what our application-based reporting looked like before we deployed our medical group productivity and operational analytics in Tableau. So as you can see, it's not really telling you anything. It's just a tabular data set that you're deriving out of an application. Every medical group wants to look at productivity of its physicians. For those of you who have worked with medical groups or are in systems that have medical groups, and this is how they actually could track it. They could just track it for a provider at a particular period in time, just tables of data with number of CPTs booked. It's not really telling you anything. And our challenge was that we had multiple databases. So as the medical group matured, they acquired practices and they were all sitting in different databases. So if you had to do this, you would have to do it in 7 different databases and then combine it all in Excel or some other tool. So very time consuming, very frustrating for leadership and for the people who are creating these reports. So what happens when a system like this exists, right? Some of these you can pretty much easily decipher, right? It's time consuming, it's inconsistent. But one of my pet peeves is answer shopping, where people actually go to 5 different people for the same information. Like I'll call finance, let me call IT, let me call process improvement, and whoever gets me the information first, I'll just take it. By the way, when the 3 teams get you the information, it really doesn't jive. Everybody's giving you a different number. So I'm sure that's a familiar scenario in a lot of organizations. So it leads to a lot of frustration, a lot of turnover, et cetera. So now to move into actual deployment lessons, what we learned. So one of the things that we did earlier on is to centralize analytics. And I realized that for a lot of organizations, it's hard. It's really hard to centralize analytics into one department. But our organization, we were nimble enough, and I guess we were small enough to do that. So we did centralize our analytics, but at the same time, our analytics kind of holds our process improvement, our business planning, and our operational redesign teams together. So what we do is, within the same department, our analytics and innovation department, we do all new business opportunity analysis. So we look at the market, we look at planning data, state data. We also do any operational redesign, because you don't want to have process improvement separate from data analytics. So we sort of put it together. So it's hard, but I think this structural change really, really helps, because what ends up happening is all your analysts are in the same team. They're physically in the same location. So it really helps because you talk to each other, you understand what the other person's doing, and it really, really breaks down barriers when it comes to analytics deployment. So when people ask me, how do you do this? How did you get your team to be so successful, and how did you deploy analytics? I sort of say these are the 3 T's of analytics deployment. One is talent. You have to have good staff and really good data science and analytics people. You can't do it without them. And you'll see that when Luis goes into his use cases. Tools, absolutely important to have good IT infrastructure. Right tools, like we chose Tableau as our analytics partner, and it's been a great decision. It's very interactive. Our users love using Tableau, so it's great. But the third, often overlooked feature, in my opinion, is tenacity, which means your ability to persevere and not give up. Because when you come up with data conundrums, it's so easy to give up. It's so easy to say, it's not really my department. I don't have that data set. How do I get it? It's probably planning has to do it, not me. So, things like that. But we have to not give up. We have to persevere. We have to talk to whoever needs to be talked to get the data. So there are challenges in every step of the way, but you shouldn't give up. And that's a very important feature of a good data science department. And just a quick note on change management, because we also drive a lot of process improvement through our department, and having the Lean Six Sigma background, the change acceleration model always comes to my mind. We talk about it from a process perspective, but from a data perspective too, right? Whenever you have any software or any analytical product that you deploy, you have to measure its effectiveness. And a lot of times, people just focus on the technical quality piece, right? You have to have good data infrastructure, good analytics, and we're good. But what's ignored is that acceptance piece. So how do you do that, right? You have, Tableau is great, we have all the data in there, we create lots of dashboards, but really nobody's using them. How do you drive that? At our organization, this engagement piece was key. And I identified ahead of time, when we actually launched Tableau back in 2012, one thing I identified was there's 4 or 5 people in my organization that are so data-driven, they love Tableau. So all I did was create dashboards for them for the first 6 months. And they became my cheerleaders. And so you have to pilot a lot. You have to identify some key people in your organization that'll drive adoption. And those early adopters then just spread the message to other people. And then as more people get on it, it becomes part of your fabric and your culture. And also remember, when you're providing data, it's always important to provide insights with the data. You can go into a system, pull the reports from the application, but what does that do? Can you connect it to more pertinent information? So for instance, if people ask you, oh, I just need, can you give me my patients from different towns or different zip codes? That's not enough. We should probably match it up against our primary service area file and secondary service area definition and then launch it there. Maybe we can map it over population. So you have to think that way when you're providing analytics to your end users. So that piece is often ignored, but is very, very important to successfully deploy analytics in any organization. Now we're going to jump into use cases. But I wanted to just quickly give you our IT landscape and architecture. So we have multiple applications, just like any other healthcare system. We have Meditech on the hospital side. We have ECW or eClinicalWorks on the medical group side. We have multiple other third-party vendor data like ADP for our payroll and Press Ganey for patient satisfaction, our state hospital association data, and hosts of other databases that we have in our application side. A lot of those are fed into our SQL Server data warehouse. So it is Microsoft SQL Server based. Everything is in the data warehouse. And then we do have some manual tracking, especially things that are collected through chart reviews and nursing documentation, et cetera. Sometimes they're easier to just collect from with a web form, because people are emailing them back and forth anyway, so might as well collect it in a spreadsheet, hook that spreadsheet up to your data warehouse, and then on a nightly basis, all of that information gets hooked up to our Tableau server. So every morning when we come in, our data feeds are refreshed, and we have data from last night. We do some basic reporting on Microsoft SQL Server also, just so you know. With that, we're going to deep dive into the actual use cases. So this is the exciting portion, so I'm going to hand it over to Luis. Here, sorry.
All right. Thank you, Divya, and good morning, everybody. So like Divya said, we're now going to see some specific use cases and reports that we have built over the last couple of years, mainly to optimize our revenue cycle management functions. And some reports are more focused on improving operational activities. So the first report that we want to show is a productivity report. And it's a quick summary of charges, encounters, and work RVUs generated by our medical group physicians. Users can filter by cost center, by provider, and in latest versions, they can also filter by service facility. And just to give you a quick background on this report, about a year ago, we used to work with a third-party vendor who used to basically calculate adjusted work RVUs for us on a monthly basis. So every month, we will pull raw claims data out of the system. It was probably like 10 to 15 CSV files. We will send those files to the third-party vendor, wait for like 5, maybe 6 days to get the data back with the adjusted units. And then we will create a static report around the 15th day of each month just to report the productivity of the previous month. So that whole process was very cumbersome. It caused a lot of dissatisfaction among users and physicians because they had to wait a lot. So what happened is that we decided to build our own calculator using SQL, with the help of SQL. So when we built that tool, our CFO basically sunset the contract with the third-party vendor and helped generate around $100,000 in savings. per year. So the report that you're looking at basically pulls data from the output of that tool that we built. So now we can report adjusted work RVUs following CMS standards on a daily basis. You don't see it here, but in some other views associated with this dashboard, physicians and users can click on a specific bar graph and get all the details behind those records. So that's pretty cool. This other report is it basically shows the volume of evaluation and management codes generated by our medical group. And we have found two main benefits of this report. First of all, from a risk management perspective, it helps us to identify trends and drifts. And that's particularly important when it comes to E&M codes. As some of you know, you can build more than once for a specific encounter. And then from a strategic planning perspective, it helps us to identify new patients per physician, right? So I'm talking about the office visits, new patients, basically CPT codes 99201 to 99205, and then initial hospital visits as well. So that's been pretty useful. This report is very similar to the previous one. Users can filter by cost center, by physician, and then see trends over time. And basically what you're looking at is a count of unique patients by gender, so that's at the top, and then by age at the bottom. And this report has been very useful for our medical group because, like we said, it's a growing entity, and we're always exploring, acquiring new practices or making new deals with physicians, et cetera, et cetera. So also, it helps you to better plan your resources. So if a physician has available capacity, you can have an idea with this report. So now I'm going to show you some of the dashboards that we have built for our revenue cycle team. So about 2 years ago, we started building a lot of metrics for finance and revenue cycle. And at some point, there were so many different metrics that they wanted to have everything in one place, right? So we decided to create this 3-page document with some of the key metrics that the revenue cycle follows every month. So the numbers have been blacked out, but just to give you a quick explanation, right at the top, you can see average charge lag. So basically how long it takes from the encounter date to the date a claim is generated in the system. So you can see annual trends and monthly trends. And then in the section below, you can see trends in accounts receivable. We have found that this report is very useful for management because you can, like in latest versions, you are able to filter by provider, by cost center, by practice, and by payer. And when you filter by payer and have all these metrics in one place, that's a great negotiation tool for management, right? Because they have meetings all the time with different insurance companies, so they can have an overall picture of what's going on with that payer. So when in accounts receivable, cash is king, right? And I think data is king now as well. So this is a very simple collections report that shows a breakdown of payments by source, right? So you have patient payments and insurance payments. You can see an overall trend, year over year, and then a monthly trend as well. And then in the section below, you can see a weekly trend. And one of the cool things about Tableau is that you can create reference lines that are based on parameters. So users can, like the medical group has a certain goal, right? A certain budget for the year. So when you open this report, you can see automatically the reference line. This is just one example, right? But then if you select a specific cost center or a specific provider or a specific facility, you might want to change the target, right? So with the help of parameters, users can just change the number. So that line will go, will move up on that or down. And then the bars will automatically change, right? So if you're meeting your target for that specific week, you will see a blue chart, a blue bar, right? And if you're not, then it'll be red. So that's pretty useful. So now I'm going to show you one of the most requested dashboards not only by our revenue cycle management team, but also by physicians and practice managers. So this is a denials dashboard. And so we have to remember that denials management is a critical piece in the revenue cycle process, and it's a big priority. You know, nobody likes to work for free, and when it comes to denials, we have to remember that there's a lot of money at stake, right? It's not just the money that insurance companies denied, but it's also the time and effort that the organization spends working out those denials. So with this report, management can easily see an overall picture of denials. And for those of you that are familiar with how denials are recorded in the system, you may know that there are different ways, right? So one claim may have multiple CPT codes, right? Multiple services during the same encounter, the same service day. And then every CPT code can be rejected multiple times if the patient has multiple insurances, right? And then every insurance company may give you multiple reasons. That usually comes in the explanation of benefits as CAS codes or remark codes. So when it comes to count denials, it's a little bit tricky, right? Are you going to count number of claims, or are you going to count number of CPT codes or CAS codes or remark codes? So with Tableau and the different functions where you can use different level of detail, functionality, we were able to build like different snapshots depending on how you want to measure denials, whether you want to count claims or CPT codes or reason codes. Another cool feature of this report is that users can So another cool thing of this report is that users can pull actionable lists, right? So let's say you want to see all the cases that were denied over the last month. So you will click on one of those graphs, and then you can see the whole details in a different tab. So that was very useful. So this is another report we built for revenue cycle. And for those of you that are familiar with how claims are processed, you know that they go through different steps, right? So what you see on the left side of this report is the claim status, right? So it can be clearinghouse accepted, clearinghouse rejected, it can be denied, then it can be a payment plan, et cetera, et cetera. It's not really a straight line, so it can go back and forth. So that's what you see on the left side. And then claims move from one status to the other all the time, right? So the aging buckets that you see at the top, basically 0 to 3 days, 4 to 7 days, 8 to 14 days, et cetera. Those aging buckets are calculated as today minus the last time a specific claim was worked or touched by any of our revenue cycle associates, right? So you can see balances and volume by aging bucket, and that's pretty useful because if you see, for example, the last column, 91 to 365 days, those are claims that nobody has worked at, in more than 3 months. So the question is, well, what's going on here, right? So a cool feature of this report is that you can click on one of those cells and get the whole list of claims that haven't been worked out in more than 3 months, right? You can see all the patient details and act accordingly. This is an expense variance report. This is not necessarily a function of a revenue cycle team. It's more like a finance department function, but we wanted to present this case because it's been a great tool for the organization to manage or keep track of expense variances. So you can see, variance by category, right? So it can be based on revenue or based on expense. It's a very simple and useful report. So now I want to show you 2 dashboards related to ambulatory services. When it comes to ambulatory services, location is very, very important, right? Because that drives collection rates and also, payer mix and ultimately collection rates. So this report right here is a quick snapshot of collection rates by location. So management can open this report and see what are the historical collection rates per location. So we have location 1, location 2, location 3, over the last 3 fiscal years. And then in this other report, we're basically building a P&L, a profit and loss statement in Tableau, using actual data. So those are the charges, the gross revenue that you see at the top, those are the charges. And then at the bottom, you have actual expenses, right? So like salaries and other non-operating expenses. But now what about revenue? So for revenue, what we did is that with the use of parameters, users can open this dashboard and type an estimated collection rate. So that will calculate an estimated revenue for each location. And those rates can be, actual, like an average of the 3 last fiscal years. Or if you're building different scenarios, you can change the rate and build a different scenario, right? So you will see an estimated net contribution to overhead per location. So I'm going to show you quickly a couple of operational excellence use cases. So the medical group, like we said before, it's a very fast-growing entity, and they're always looking to make the best use of their resources. So what you're looking at is a physician office wait times dashboard, and by that, it's basically the number of days it takes, or the number of days between the time a patient schedules an appointment with one of our doctors and the day the patient actually has the appointment. And this is particularly important for the medical group because they're always trying to see if there's available capacity in some locations or with some physicians. And if it's not the case, then they also want to know if they need to allocate more resources to a specific facility. So that's basically the main use of this report. This is a patient panel. It's actually a very simple report. In Tableau, you can do a distinct count of any variable, right? So in this case, it's just a distinct count of, I believe it's patient IDs. And just like the previous report, it's very helpful when it comes to measuring available capacity. So you can see very quickly the number of unique patients per physician, right? And see if you can allocate more, if you can make more appointments with that physician, or if that physician, or see if that physician needs more resources. So when we started to building all these different metrics for our operations department, we wanted to have a centralized, like one-stop shop for all, for our COO. So we decided to build this practice dashboard, which basically combines different types of metrics. So for example, at the top, you see the average patient arrival per hour. And this metric can be filtered by cost center or by facility, and even by provider. And then in the middle, you can see the percentage of appointments by visit status. So right at the top, you see the checkout visits, so basically visits that actually happen, visits that were canceled, visits that were rescheduled. You can see no-shows and other different visit statuses, right? So it's basically a good way to have a snapshot of your no-show rates and cancellation rates. Then another cool feature is that we were able to pull data related to the type of visits. So you can see the percentage of new visits versus established patient visits. We also included information about referrals, physician productivity, so those are the adjusted work reviews, and finally, the number of hours or resources that were needed to achieve that level of productivity. So as you can see, there are like many different type of metrics in just one place, and we did that through data source blending and other tricks in Tableau. So this is called an imaging service capacity tracking report, and it basically, it was created because of a lack of transparency around imaging volume in our radiology department. They basically wanted to know which were the busiest times of the day. So this is what we're showing, right? It's a heat map where you can see the volume of procedures per hour, right? So you can see that Thursday, Tuesday, Wednesday, Thursday between, I would say 10 a.m. and maybe 3 p.m. is where you have the busiest times. So our radiology manager uses this report a lot and helps her allocate more resources at a specific time of the day. And then at the bottom, you can also see the volume per hour, depending on, and then by day, right? So those are the different colors that you see at the bottom. And just two quick things. This is not really a dashboard, but I wanted to mention that with Tableau, you can easily filter databases. And this is a use case where we use Tableau for that purpose. So we wanted to identify patients who had CPT code 92960. So it's basically patients who had a cardioversion electric, basically shocks, right, to revive. And then we wanted to see how many of those patients hadn't visited the electrophysiology department in a year. So in Tableau, you can quickly replicate a data source. So in the first data source, you just pull all those patients that had that CPT code, right? And then in the copy, you can just use those visit IDs, those patient IDs, paste them as a filter, and then filter by location, right? So if the location that you're selecting is EP and it's null, so that means that those patients don't have an EP visit. So it's kind of like an ad hoc request, and Tableau is very useful for those kind of situations. And the last thing I want to show you, it's this. So one of the initiatives that our Medicare group launched a couple of months ago is called Responsibility Indicators and Objectives. It's basically a group of metrics that they want to use to measure performance. And all of these metrics were already developed in Tableau. The problem is that they were in many different workbooks and dashboards. So, and it was a little bit hard to combine all of them, so it made a lot of sense to keep them separately. So one of the cool things that you can do in Tableau is assign tag. You can tag your workbooks. So in this case, because the abbreviation is RIO, it was very simple, right? We just tag every workbook that we needed with that abbreviation. So physicians can just open the Tableau server, type RIO, and then pull the list of workbooks and dashboards that they need. So, and they can also subscribe to these reports. So sometimes physicians, don't really want to log into so many different applications. So that's another cool feature, right? So you can subscribe and get a snapshot of this report on an ongoing basis, right? Every week, every month, or whatever. So now Divya is going to present some surgical service use cases. So.
Thank you, Luis. So we want to deep dive into some of our surgical services use cases next. So one of the things that let me just give you a quick recap of what a block is for those of you who are not familiar with perioperative services or surgical services. Essentially, it's a block of time that you assign to a particular practice, a physician practice, or a particular doctor, a particular surgeon, because OR is a very expensive resource for any healthcare organization. I believe an OR costs you, I think, $35 to $40 a minute. So it's a very expensive resource. So you don't want any OR time to go waste. So the entire concept of block utilization is that you want physicians who are assigned a particular block to use it and not go out of that block. So it's very important to measure in-block and out-of-block utilization as well. So what we did here was create a dashboard that looks at block utilization by owner. On this side, I realize I'm ignoring this side. So this is your particular, so this is MD Block 7. So you can look at your percentage of utilization, which is essentially the in-block surgical time plus the TOT, which is turnover time. It's important to measure both. And turnover time is the time between two surgeries. So if I'm assigned a time from 7 a.m. to 11 a.m., I do a surgery from, say, 7 to 8:30, and then by the time they room the patient out, then they bring the other patient in, it's half an hour, another half an hour. You need to count that because that's considered as part of your in-block time. So do that and divide it by the total allocated time to the block. So we were able to pull our our OR scheduling data sources and pull this block report together. Just to mention, this was outsourced to a vendor. They were using a product from another vendor. Once we developed this report, it was much more accurate and consistent and more real time, because that other vendor, we were submitting them the surgery schedule data on a monthly basis. And the one thing that you can see here is that not only do you get the overall utilization, but you get that individual breakdown. Because whenever you do something like this, there's always glitches, there's always bad data. There might be a case that got scheduled but was not canceled out. Even though it was canceled, it's still showing up in the system. So you will have some zeros. So it's always important to have the raw data to look at. And then on the right side, our OR managers can look at just total utilization using a heat map by every block that's assigned. So they can see which physicians are actually having a higher utilization ratio versus those that are not using it at all, and accordingly communicate to those physicians or move their blocks or have the conversations about why they're not using the block time. This is another spin on the block utilization. It's room utilization. And this, once we started developing the block utilization metrics, this was the other sort of spillover that they wanted to also look at how much is the room utilization. So what is room utilization? Essentially what you're trying to do here is look at your busiest rooms at the busiest times of the day. Right, so you're looking, and that's exactly what this is showing. On this side is the room utilization itself, and then on the other side is time bin utilization. So you can, we have time bins that are OR management, 7 to 11, 11 to 2:30, or whatever the time frame is. But essentially, you can look at by individual blocks and by individual rooms. So you know that at the hospital, OR1 is used most often between 7 and 11 a.m. So you know that a physician requesting a block during that time, you'll have a hard time giving them that time. So you can be transparent. This actually is being used in our OR committee very actively to monitor blocks and to assign OR times. And it gives our surgical department chairs a lot of ammunition to go and talk to those physicians that have poor utilization, which is very important, because good data is very important, because if they have used it, but you don't show it in the system, you're going to have a hard time, and they'll lose trust in your actual, that whatever product that you're showing them. So there's a lot of scrutiny that goes into it. One of the things that I want to mention as we did this was physician vacations were a huge issue. So when we were sending it to an outside vendor, let's say a physician takes a week off, their utilization is going to be way off, because you're measuring it by the month, right? And they're, whatever the 5 days of the week that they had the block, you're not going to show up. So now what we did with our system, because it's coming directly from the scheduling sources, we trained the OR staff that are booking the surgeries to book vacation. So we have a protocol for putting the vacation time in. And we have filtered that vacation as a vacation code, and we filter it out of the denominator. So it doesn't affect their total block time. So even though it's a simple bar graph, there's a lot of process work that has to go in, and a lot of optimization that has to go into to track this stuff. This is for our surgical services contribution. As you know, in any healthcare organization, any hospital, surgeries are the most profitable service line. And we track our profitability by surgical service type. So, our general surgery versus orthopedics versus breast surgery. So what we can do here is for each group, this waterfall chart is a great depiction of, you can actually track your profitability by month. So the months are at the bottom, so you're tracking your profitability, but then at the end of the year, you can look at how you did overall. And you can, the light gray, I'm not sure if you're able to see, but that's the volume for that particular service. So you can also say, hey, our profitability went down this month. It was because of low volume. We didn't have enough patients. And then this can be used in conjunction with looking at physician schedules to see, oh, that's because we have 2 cardiac surgeons, one of them was on vacation 2 weeks. So yeah, our volume was low because of that. So there's a lot of support that the OR management gets using these reports, when you put them all together. This is another use case, a very simple list for our infection prevention list. So what essentially happened was our surgical administrative staff was sending this letter that you see here on the left side. This was a letter that they sent out to track infection. So the challenge was these physicians were independent physicians or outside physician groups. So we asked them to send us certain complications or surgical site infections. So what the people were doing is actually going into the EMR, pulling a list of all surgeries done that month, then sorting them in Excel, and these are administrative folks, right? So they're not really data analysts. So it took them hours and hours of their time just to create this list that they then send out to these physicians and ask them to track those 4 things that they were supposed to track for quality purposes. And they sent them this. So what we did was simple list in Tableau, pulled all of our schedules, pulled all of our completed cases, and created this Tableau worksheet that that they could send out. A challenge here, so initially we developed a subscribe feature, but then we realized because it's HIPAA violation, it's patient level data, we couldn't send it to a doctor's personal address, so because they were independent physicians. So we had to come back to PDFing and sending it out via encrypted email. So just a challenge, but but it still saved our administrative staff like 4 to 5 hours a month. Again, on the maternity side, for our maternity procedures, we looked at MD Scorecard that we developed for our OB chair, essentially to track a physician performance, both in terms of volume and quality. So what you see here is the by DRG breakdown of all the deliveries and OB procedures that have happened. But on the right side, you see this quality check for vacuum-assisted and I believe it's postpartum hemorrhage. Yes, so postpartum hemorrhage. So you could see for that particular physician or OB that you filtered, you can see what their cases are and how many were postpartum hemorrhage or vacuum assisted. And then at the bottom, you still see a trend for the volume overall. But as you know, every hospital tracks their C-section rates, and this is a great way of tracking C-section at the physician level, so you can have those conversations about individual physician C-section rates. What it essentially does is it just does a table calc, so we grouped our C-sections, normal deliveries, and other, and then we just said, is your total greater than the average for the group, or is it lower? So it just sort of helps our department chair have that conversation. And it's a simple table calc that helps us do that. And also creates a culture of transparency because you're sharing all this information with physicians. It's not a black box, and you're not saying, oh, your C-section rates are high anecdotally, So with that, I'm going to dive into some clinical quality and population health use cases. Quality reporting, as you know, the MIPS and MACRA stuff hit us last year. I think, and one of the things that our organization wanted to do is communicate or submit the MACRA quality scores as a system. However, CMS has a rule that if you have 2 different systems and 2 different organizations that want to submit as one entity, you have to have a 50% overlap. So the challenge there was we have 2 different systems. We have Meditech on the hospital side and eClinical works on the medical group side. So how do you know if for every measure you have that, every measure submitted, you need to have that 50% overlap. So what we did here using Tableau, and we wouldn't have been able to do it without Tableau because what we did was we took the clinical data from eClinical works, then we took our master patient index that our data warehouse team had developed using got the data from our Quantros EMPI solution, and we mapped the patients and essentially did for overall, how many are in Meditech, how many are in eClinical works, and then how many are overlap. And that overlap had to be 50% for us to qualify. So with this report, we were able to show that, and also show the number of shared patients as well. This is a custom quality report that we've developed for every physician on our medical group by specialty. So this dashboard particularly is for cardiology, as you can probably tell from the measures there, but essentially for every physician, we track these quality scores. We have the average running. That's a great feature. You could just put the average, I'm sorry, not the average, but the goal. So we put the goal for the year. And then we have numerators and denominators, because as you know, in quality reporting, especially when it comes to physician-level quality reporting, just the percentage doesn't help, right? You tell a doctor your mortality rate is 5%, 10%. It doesn't really matter if they did one case, it depends on what the total denominator was or N was. So we did this report, and as you can see, the N and D stand for numerator and denominator. It is running by physician, and each one of those tabs up top is for each specialty. So we use this to actually set incentive bonus, quality-based bonus, so that our physicians deliver quality care. And they use this to actually discuss this with our physicians as well. And you are able to benchmark and compare against peers as you do this. This is a cool dashboard that we developed because we found that a lot of our patients weren't coming back for physicals. So a simple solution was to just do a count of patient account numbers by last appointment date and then sort them in years. So what we did was we just said, okay, this particular practice, how many patients came for a physical 2 years ago but never came back, essentially is what this is saying. So what we did was, as you can see, 2018 is the biggest, obviously, but you see a lot in 2016, 2015, 2017. So if it's 2 years, why are they not back for their physicals? So we, alongside this overall dashboard, we developed a line list of patients in Tableau where we now can call individual patients and say, hey, you came for your physical in 2016, we haven't seen you back, do you want me to schedule the visit? And it's the right thing to do for our patients. It increases and maximizes our patient retention and satisfaction as well. And a very easy report to build. Any healthcare presentation is incomplete without length of stay data, so I had to put my length of stay slide in here. Every hospital that I know of is working on length of stay projects, right? So this is our length of stay projects, and we did a lot of data dive, just FYI, there were length of stay by physician, by DRG, by unit, by nurse, everything you can think of. But finally, as the process improvement team and our project manager were struggling with it, one of the things they realized was this heat map actually led them to believe that most of the challenge was happening between 1 and 4. Our goal, like any other organization, is to discharge by 11 a.m., but clearly it wasn't happening, right? It was all happening between 1 and 4. But now what was happening between those times is also, when we shared this with the team, our OR people said, wait, but that's when we're transitioning a bunch of people from the surgical side to floors, right? Because surgeries are being completed around 11, 12, then they get the patient ready in the PACU, send them by 1 o'clock. So that's the same time patients are coming in. They're also trying to discharge patients. That's what was causing the confusion. So as a result of that, they started doing these fast rounds, which is focused and safe throughput rounds. Essentially is an interdisciplinary rounds with our hospitalists, our nurses, our case management, social work, every morning and every afternoon. And as a result of that, we've reduced length of stay. But if we didn't have this data to analyze the root causes, we wouldn't have been able to do it. Another quick thing, this bubble chart actually helped us analyze the after 3 p.m. discharges. So they looked at those delays, like why are so many patients being discharged after 3 p.m., this section. And what they did was divided after a chart review of, I believe, 300 or so cases. They grouped them into clinical and non-clinical delays. And one of the things they found was that transportation was the biggest problem for non-clinical delays. It's a problem that they then try to tackle. They're like, can we get you taxi vouchers? Can we get Uber? Have a conversation with the family so that IDT, the fast rounds, help with that because they identify if a patient's going to have, okay, this is an older lady, she's in her 80s, she needs her son or daughter to come and pick her up. Son and daughter works, can't come by 5 p.m. Things like that. So we were able to really use data to drive some of that process change. And we have had a length of stay decrease of about 0.5 days. This is a little old. This month, the data came back, and we're actually trending at a half a day for the year. This is a quick chart just to kind of show you the mapping feature for Tableau. We have used this for demographic analysis by practice. Each one of our sites has a number of patients, and we have outreach across Fairfield County. So we are able to site plan and see which physicians to place in which sites. So measurable value from analytics, as you have seen, we've both, between Luis and me, we've shown you a lot of use cases, but one of the things we find hard to do is quantify the actual savings or potential savings that come out of it, because every denial that you track is actually, technically, we've helped you track it and collect it, right? So we estimate it at higher level to be about $5 to $7 million since we've implemented Tableau. We've eliminated about $250,000, $300,000 in software analytics, software and consulting costs. And we've improved our collection rate, as you saw from all those dashboards, and we've reduced our length of stay by about half a day. So with that, one more slide. What are we doing next? So we've done a lot on the finance and on the operational side. We're looking to now do consumer analytics and help our marketing and planning department enhance some predictive analytic capabilities and expand our supply chain savings analytics. So with that, wrap up.
Thank you, Divya and Louis.
Thank you.
Perhaps the only presentation where you'll see this broad depiction of use cases from so many lines of businesses, which hopefully was valuable. We have time for a few questions. Any questions from my colleague Kyle will take questions from that section. I can come to you if you have a question here. Do you have a question there? Okay, we'll take you first.
Hi, thank you. I'm over on this side, to your left. Hi.
Oh, hi.
My question is this: it seems like you have consolidated a bunch of analytic silos from across the organization to kind of get to this level of richness of data and analytics. And I was curious, as you've done that, have you thought about how to create different roles within your analytics team for folks to do a lot of the requirements gathering and really understanding what are the actual insights, the people who are actually doing the data modeling, the people who are focusing on Tableau. So how are you, as you become a bigger analytics team, what have you done to make sure that a lot of these dashboards ultimately are meaningful and there's efficiency in how they're being built?
Right, that's a good question. I think you always run into challenges, especially as you're developing a team and the organization is starting to see the value of having a central team. I always struggle. I think we constantly struggle, but I think having the whole team together as a team really helps because they learn off of each other. And also the overlap in the data silos, in the data sets reduces, right? Because if I'm doing planning analysis and I'm trying to understand the business opportunity, but then Luis is doing the financials, I can go up to him and say, hey, I'm looking at this market. Can you just run me a P&L for this area? And he can do that because that's his line of expertise. So it really helps having a central team. The challenge is that it's really hard to bring them all together. Even now, we struggle. There are certain departments that would not give up their analytical oversight. So the way we've overcome it is to have really good analytics on the Tableau side. If you have a better tool, they will eventually come to you, is what I say. But it's a constant struggle. So I think it's a great question. Yeah.
Hi, I'm Hardeep from Canada, BC. Great presentation. Thank you for sharing everything. Can you talk a little bit about your change management a bit more? We're just starting our journey now. And how did you get the people? We've got 25,000 practitioners out in the field. So the real value of this is when people make decisions based upon the data you're presenting. Can you talk a little bit about the adoption and how people in the field are actually using the information in their day-to-day while serving the patients?
Right.
Thank you.
Yeah. So I think that change management slide that I showed, again, I think the technical component is very important. So your data has to be right, especially when you're sharing it with physicians. So you have to check and recheck and make sure the data integrity is there. Do not roll it out if it's half-baked, especially when it comes to people's bonuses and it comes to people's quality scores because they're personally attached to it. Secondly, we always look for early adopters. Look for people who will love your data, will not love your data in the sense that, love the tools that you're deploying, I should say, and use those early adopters as your cheerleaders and make sure that you deploy the right tools to them, because you cannot boil the ocean. You know, when I started this journey back in 2012, I had one person, one contracted employee and myself, and we had to develop for the whole organization. I couldn't have done it if I tried to do it. So you have to take it slow, one day at a time, identify a group of people, pilot a lot of reports. That helps, because some of them fail, some of them succeed, and then you deploy it across the board. But Tableau is a great tool, because whether you have 5 doctors or 5,000 doctors, you still can develop the same tool and have the same filters and deploy security around that.
Hi, my name is Nisar from Cope Health Solutions. I saw one of your dashboards, you're talking about data blending, and you obviously used a lot of data. How do you come about dealing with some of the issues that arise with data blending and using such large sets of data, whether it comes to performance or filtering? Do you have any suggestions around that?
Right, yeah, when it comes to data blending, there are definitely some limitations, right? When it comes to filtering, grouping. So it really depends. If sometimes we use data blending for kind of like urgent requests, but if we see that specific report is gonna be requested over and over again, we reach out to our data warehouse team, because they built all our data sets in SQL, and then we ask them to do the right joins on the SQL side, right? So it's on a case-by-case basis, but if it's a report that it's urgent, right? Like they need the data right now, we do the blending function, right? But ideally, we go to SQL and fix the view, the data set itself.
Yeah, we try to do most of the heavy data blending in SQL and not do too much of blending in Tableau.
Last question.
Sure. So my name is George Benavente from the Villages Health. Great presentation. Thank you. I'm really interested to know what's the process at your organization for having those conversations with physicians, because a lot of the times they tend to be really resistant to the data, especially if it doesn't, shine light on them. So can you talk a little bit about the process at your organization?
Yeah, sure. Yeah, you have to develop a thick skin. I mean, yeah, they yell at you, they send you things, they throw things at you, and that's just part of life, I guess. But as I said, data integrity is very important. And what I try to do is find a friendly physician, one person who actually agrees with us, or usually it's the chair, the department chair, because if you can get them on your side, if somebody who's a physician champion can understand your data and understand where you're coming from, they can convince the others. So it's always easy, again, as I said, to have those early adopters or people who can actually sort of help you navigate that. But you have to make sure that the data is correct, because otherwise, it's going to be thrown out at the first glance.
Thank you.
Cool, that's all we have time for. I'd like to take this opportunity to thank Dr. Divya Malhotra and Luis Rodriguez.
Thank you.
As you can see, it's an amazing body of work, and we really appreciate her willingness to share it with the broader healthcare community. So thank you very much.
Thank you. Thanks.